Thank you very much, Yasuband, for giving this introduction into the policy recommendations for the Indian context. I'm inviting you now all to pack antimicrobial resistance into your bag and follow me all the way from India to Germany. My name is Dennis, and I'm going to present the policy recommendations for the Metropolis in Germany on behalf of our group, consisting of Anna Brückner, Juliana Minetto-Gellert-Paris, Philipp Svoboda, and myself. So as I said, antimicrobial resistance is a global problem. The key driver of antibiotic resistance, which is a subset of antimicrobial resistance dealing with bacteria, has been identified as inadequate and excessive use of antimicrobials or antibiotics in humans, animals, and the environment. On the bottom left, you can see a figure that shows the change of antibiotic use defined as defined daily doses per 1,000 inhabitants per day between 2000 and 2015. What we see is a stark increase for upper middle income countries as well as lower and lower middle income countries. What we also see is that high income countries remain more or less stable, however still at the highest level. Globally, this is how it is distributed. So you can see in the map blue areas that indicate a decrease in antimicrobial use, and you see red areas that indicate an increase. You also see a lot of blank countries where we don't have any data. May I draw your attention to the bar chart below? What you do see here on the left-hand side, which indicates high antibiotic use, a lot of dark blue bars, which indicate high-income countries. Towards the lower end, indicating lower use, you see a lot of low and lower middle-income countries. Germany is positioned in the lower half here. Let's zoom in a little bit. In 2019, there was a study that estimated the burden of antimicrobial resistance on Europe. They estimated that there were roughly 670,000 infections with resistant bacteria. Of those, roughly 64% were associated with healthcare settings. Of those, there were more than 33,000 deaths attributed, estimately, to antimicrobial resistance in 2015. This was back then quite a high number, which was surprising. On a regional scale, this is how it looks like. You can roughly identify a north-south gradient, with northern countries being usually a little better off than southern countries in Europe. Germany, here positioned geographically at the center, ranks in the lower third in terms of antimicrobial use. And in the figure, you can see the antimicrobial use in the primary care sector. In terms of antimicrobial resistance, there are promising developments. Let's look at Germany. If you look at the resistant isolates, or the percentage of it, for methicillin-resistant Staphylococcus aureus, which is a bacteria that is responsible for many nosocomial infections, so infections that you acquire in a healthcare setting, we actually see, starting in 2000, numbers around a little above 10% that started to increase, but also actually started to decrease, ending in 2019 at a lower level than it started in 2000. However, we also see concerning trends. If you look at gram-negative bacteria, for example, here we have Escherichia coli, which is a commensal gut bacterium, and it's resistant to third-generation cephalosporins, which can be roughly considered the second line of treatment against such bacteria. We see that the map gets a little more yellow and a little more orange. Germany is again positioned somewhat in the middle here, but we see that between 2000 and 2019, the percentage of resistant isolates increased up to 10% roughly in 2019. If we zoom in further, let's go to Germany now. Here I want to highlight 2 points, the human and the veterinary medical sectors. In human medicine, AMR tends to be constantly lower at lower levels compared to other countries. AMR here refers to antibiotic use, for example, or what we also saw earlier, the resistance level of certain bacterial species. However, we have distinct geographical differences. If you look at this figure, taken from the very last report on antimicrobial use in human and veterinary medicine in Germany, unfortunately from 2015, we see 16 federal states. Northern Westphalia, the one where we are located in right now, ranks in 2014 the highest in terms of antimicrobial use. In the veterinary medical sector, we see a decreasing tendency in antibiotic use. In 2011, the monitoring started with roughly 1,700 tons used. In 2019, those numbers are down to roughly 670 tons, a huge decrease. However, we also see regional differences across Germany. If you look at the map, you will see a lot of yellow areas that indicate lower than 5 tons of antibiotic use. However, you also see different shades of orange. which indicate higher use. Here you can see our study area, the room Metropolis, covering parts of orange areas. Why do I tell you all of that? Well, because antimicrobial resistance is how One Health is currently mainly operationalized in the German system. Over the past years, the added value of One Health has also been increasingly recognized in Germany. Take, for example, the World Health Summit that just concluded yesterday. The State Secretary of the Federal Ministry for Economic Cooperation and Development highlighted that One Health will be one of their main pillars for the upcoming years in terms of international cooperation. But also the Federal Ministry of Health established a department on One Health, focusing on antimicrobial resistance. So the One Health approach in Germany is mainly institutionalized and operationalized at the federal level in the context of zoonotic diseases and antimicrobial resistance. You can see here, for example, on the top left, the DART 2020, which is our German antimicrobial resistance strategy. You can also see a memorandum of understanding between several ministries in terms of research on One Health. And you see the German One Health initiatives with its partnering institutions that are all out at the federal level. One Health has also been taken up by the academic sector. For example, our very own research school that we represent today here, One Health and Urban Transformation, is a very prime example of that. But also other joint health research institutions. And we should not forget that in 2018, the University of Bonn organized a big conference on One Health and food safety. However, many regulations and policies that protect and promote the health of humans, animals, and environment are still widely kept separate. This brings me to my first policy recommendation, not to my, but to our recommendation actually, for the room Metropolis. So One Health is mainly institutionalized at the federal level. Regulations and policies are kept separate. So we argue that it makes sense at the local level to start by setting up a One Health committee. You can set it up either at the municipal or the regional level. And its task would be to enable and foster intersectoral coordination and collaboration among relevant stakeholders. Because if you want to bring together stakeholders from humans, animals, and environmental health, this is quite a large number, and someone needs to coordinate that. But let's talk a little bit more on the room Metropolis. A little fact refresher here. The room Metropolis is an urban polycentric agglomeration in the western part of Germany, and it hosts approximately 5 million inhabitants. Due to its past, it's right now concerned with major urban transformations that are ongoing. Ongoing changes include, for example, the co-presence of urban shrinkage and urban growth, the increasing social polarization and segregation, the aging of a highly diverse population and the rising prevalence of non-communicable diseases, and the loss of fertile soils, as you can see in the graph on your right-hand side. This is taken from a study in 2013 and highlights that agricultural areas or soils are lost when with this all associated ecosystem services as well. So let's come to the remaining parts of our policy recommendations for the room Metropolis in Germany. So the local processes I just highlighted, in addition to other global processes such as climate change and with it, for example, extreme weather events, they result in an alteration of critical intersections between humans, animals, and the environment. For Germany, the room Metropolis in particular, we therefore envision One Health to be more than the classical version of it. There's more to One Health than zoonotic diseases and antimicrobial resistance. And for this, we need 2 points. First of all, One Health in all policies. This is very similar to the World Health Organization's initiative, Health in All Policies. What we mean by it is that the nexus of human, animal, environmental health needs to be integrated in the One Health concept in all policies, and not just those that are obviously linked to health. Secondly, it's important to not just consider pathogenic, so dangerous to health intersections, but also health enabling, so salutogenic intersections. In the following, I'm going to present to you 2 examples of what we mean by that. The first example would be the food system. The food system itself is a very complex system that requires holistic solutions. In the room Metropolis, we see a shift in dietary and production patterns. Dietary patterns, for example, have transformed more towards animal-based, highly processed and energy-dense foods, associated with a lot of non-communicable diseases that we see. Production patterns in the room Metropolis are mainly dominated by large farms that practice intensive agriculture that aim for maximizing the output per area. You could apply an integrated view here. Let's take, for example, human health, animal welfare, and agricultural sustainability. You could argue that human health is mediated by animal welfare and agricultural sustainability. So improving animal welfare, for example, or working on agricultural sustainability might also actually improve human health. What we also argue is that One Health approach can be adopted throughout the entire food supply chain. You could start by intervening at the one or the other stage, like the consumption stage or the production stage, but you can also do it jointly. The second point, moving away now from the food systems, would be One Health as health promotion. So the role of the environment, and particularly healthy environments, whatever you want to define it with, on health of humans and animals is well established. In this context, for example, urban regeneration for urban green and urban blue play a major role, and a very critical one. You could, for example, improve the health of humans, especially the mental health, by revitalization of brown areas, for example. This brings me to policy recommendations 2 and 3. So the consideration of both salutogenic and pathogenic intersections. Start small, start local. Develop and implement local One Health interventions. This could be, for example, a multifunctional green and blue space linked to urban agriculture and community gardening. And at the same time, you might even be able to also reduce flood risk. Or you could set up an integrated wastewater surveillance system. This is highly debated now in the context of SARS-CoV-2 and the COVID-19 pandemic. But before that, antimicrobial resistance was a prime example for wastewater surveillance, because by using an environmental compartment, you could monitor what is actually circulating in the domain of animals and humans. Thereby, you should still consider path dependencies and the need for holistic solutions. This brings me back to our example from the food system. You could, for example, promote healthier diets at the consumption stage. You could also argue for clear subsidy schemes that promote animal welfare and soil health, for example, at the production stage. But you can also do it jointly. Policy recommendations 4 and 5. The integration of One Health concept in all policy fields. At a certain point, it makes sense to start integrating the One Health interventions that you started to do at the local level into an overarching One Health strategy. This process can be ideally led by the One Health committee that was set up in the first place. And lastly, you could establish a One Health monitoring system in the area. The task would be to analyze or gather and analyze data, but also disseminate information to relevant stakeholders and conduct integrated assessments of challenges, needs, and impacts in terms of what is going on in regard to One Health in your area and where you need to adjust. Based on this One Health monitoring, you can adjust your system, for example. You could try to set up new research projects or start new interventions. In summary, One Health is so far mainly institutionalized and operationalized in Germany in the context of zoonotic diseases and antimicrobial resistance at the federal level, as I explained earlier. However, we think that the Metropolis context provides a unique opportunity to move beyond the classical One Health approach towards an extended version of it. Remember the examples of One Health for health promotion and the food system. To just briefly summarize our policy recommendations. First, setting up a One Health committee at a lower level. Development and implementation of local One Health interventions, thereby considering path dependencies and the need for holistic solutions. The third point I did not touch too much on in my presentation. It's still part of our policy brief. The development of innovative funding models. You could cooperate with health insurances in terms of health promotion that is linked, for example, to urban green and urban blue spaces. Fourth, integration of One Health interventions to an overarching One Health strategy for the area. And fifth, and not lastly, establishment of a local One Health monitoring. With that, I would like to thank you very much for your attention. We will look forward to your comments and questions at the end of this presentation. And I'm now inviting you to follow me all the way from Essen or the airport in Düsseldorf to Sao Paulo, where we will hear more on the extended version of One Health. Thank you very much.